Hello friends, good evening. I'm Dr. Aishvarya Kaushik, your original guru for conservative dentistry, endodontics and dental materials. Well, today was an important day for all of us guys. Today was our INI MDS examination and I'm here with the recall questions for dental materials, conservative and endodontics guys. So let's quickly discuss them. 18 to 30 fluted burr is used for. It's a finishing burr, right? If you want to do polishing, it would be much more finer than that, right? If you want to do, gross cutting, it would be like a 8 to 12 kind of a fluted burr, configuration. So 18 to 30 fluted burr is a finishing burr. No doubt about this. That is the answer. Simple question. Then there was again a very important, repeat question in which two images of deep carious lesion was shown. So what was the image like? It was something like this. Two images, adjacent images in which, a deep carious lesion is shown in which the remaining dentine thickness is pretty less, guys. Here, as you can see here, it's pretty less. It's not really mentioned as to what is the, remaining dentine thickness, but you can understand that it's pretty less, almost approaching 0.5 mm. Here also, if you see in this diagram, pretty, less remaining dentine thickness from the pulp chamber. So in both the cases, you will be doing, protecting any kind of inadvertent or microscopic pulpal exposure with calcium hydroxide. That's the classical, dical that you can use to protect it, then overlay it with a resin modified GIC to protect it, and then do your composite restoration. Modern day, you can do MTA or biodentine as a, indirect pulp capping agent. However, in the options, MTA biodentine was not given, making our life easy, right? So the answer is simple. You do calcium hydroxide as a liner for both the cases, right? No doubt about this, guys. Then we have an image-based question. Very interesting. The tooth has suffered a subluxation injury. So this, when you see this question, your head should directly go into the management of subluxation injury, right? So let's just take this one by one. We have a image-based question, subluxation injury, wire and composite splinting can be seen to be done in the clinical management. So it was something like this. If not exactly like this, but something like this, right? Here, instead of, this, like simple wire, it was not, the wires were not going interdentally, right? It was two twisted wires, twisted along the long axis, right? And they were supported by composite blocks, right? On the labial surface of the teeth, right? So, first of all, before seeing the options, the best way to not get confused is, what is the correct management of subluxation injury? First of all, if you might just not do anything. If the patient is fine, he's not complaining of severe pain, just don't do anything. In subluxation and concussion injury, you just keep the patient on follow-up. However, to slightly relieve the pain, you can do flexible or semi-rigid splinting for 2 weeks for the relief of pain. The periodontium is going to heal by itself, right? You just have to tell the patient, just don't eat anything hard, give it some rest. So the question was interesting in the sense that he had asked you a further question. Semi-rigid splinting for 2 weeks, no doubt is the correct answer. But further, the examiner is trying to confuse you by saying semi-rigid splinting for 2 weeks for the relief of pain, but with no effect on the periodontium. That is the correct answer. Semi-rigid splinting for 2 weeks, which will relieve the pain as well as help in the heal of the periodontium. No, that is not the correct answer, right? Obviously, rigid splinting for 2 weeks, rigid splinting for 4 weeks, that is immaterial. They are not the correct options. So the correct answer here is, guys, this is a good question actually. So the correct answer here is semi-rigid splinting for 2 weeks for pain relief without having any effect on the healing of the periodontium. The periodontium is going to heal. Even if you do not do splinting, the periodontium is going to heal. All right, then image-based question, simple question in which a luxation injury was shown, and very clearly it was a case of lateral luxation. The crown was, tilted lingually or palatally, and the root was displaced labially. So it was a classic case of, lateral luxation, something like this. It's like you get a blow when you hit a wall, or when you get a traumatic injury while having a fight, right? So the labial surface, the crown is tilted palatally or lingually, and the root comes out labially, right? So it's a classic case of lateral luxation, no doubt about that. That is your answer. So lateral luxation is our answer here. Then we have an IOPA X-ray that is shown. All right. There is history of trauma. Age of the child is 10 years. Very clearly, the lateral incisor. So on the IOPA X-ray, you can see the lateral incisor with an open apex, and the central incisor with closed apex, right, guys? EPT was negative, of course. Some amount of periapical radiolucency was seen mostly in more in this lateral incisor, less in central incisor. Both are obviously non-vital. What is the correct ideal treatment here? Now here, see, since central incisor is a closed apex case, it's non-vital. You will do routine root canal treatment in this, right? Debridement, root canal treatment. Now, what are you going to do in this open apex case? You can do apexification, you can do revascularization. Since it's an open apex case, it would be great if you try revascularization and be successful in that. So the answer would be revascularization of lateral and obviously RCT of central. Right? Apexification, the option A, that is apexification of lateral and RCT of 1-1 is also not wrong, but a better option would be revascularization, attempt revascularization of this open apex case. Try to, gain some strength in the root of this young 10-year-old kid. And so revascularization is a better answer for lateral incisor. Normal root canal is obviously the best answer for the central incisor. Then you have another X-ray based question in which, again, you have an open apex case. Yeah, right? Young child. Now, in the first X-ray, first IOPA, there is a filling material which is, like a temporary filling material, like a radiopaque filling material, only in the pulp chamber, right? And in the second X-ray, the examiner clearly mentions that he's using Metapex, right, to fill the entire root canal. So you can see basically what you see is that you have a first X-ray, and yes, it is an open apex case. So here you have a, like a temporary filling in the pulp chamber. But more importantly, in the second X-ray, what do you have? You have an open apex, right? But the entire root canal is filled by a proper radio-opaque filling material, which is, the examiner is mentioning, the question is mentioning Metapex. Now, Metapex is what? It's a combination of calcium hydroxide and iodoform. So basically what you're trying to achieve is, when you fill the entire root canal with basically calcium hydroxide, and Metapex means that you're planning to basically place your intracanal medicament for a long period of time. So what are you trying to achieve? You are trying to achieve a calcific barrier over this hard tissue barrier, over this open apex non-vital tooth. So you're trying to achieve apexification. Your aim is apexification. Therefore, the correct answer here, guys, is apexification. Simple. What is the best medium for transport of Eval's tooth? The examiner, to confuse you, gave you both Viaspan and Hank's balanced salt solution. Just to be very clear, if neither is given, neither Hank's balanced salt solution or Viaspan is given in the options, then milk becomes the best answer. If either Viaspan or Hank's balanced salt solution is given, then they become the better answer over milk. If both Viaspan and Hank's balanced salt solution is given, then Viaspan is a better answer. Both are good, but Viaspan is a better answer. That is what you have to memorize. Can't help you with that. A patient reported after 2 months of replantation of avulsed tooth. So replantation is clearly given. You know, the tooth was avulsed, it was reimplanted. Right? He was asymptomatic, okay. The tooth was not mobile, fine. On percussion, a high-pitched sound was there. What is the diagnosis? The answer is replacement resorption, guys. Right? Although replacement resorption takes place as a result of external resorption only, isn't it? Replacement resorption is also a result of external resorption only, but a better answer would be replacement resorption, specifically because, you know, there is a high-pitched sound, a metallic sound on percussion. If this was not mentioned, then the answer would have been different. Why? Because after traumatic injury, the first thing that is going to take place is external inflammatory resorption, right? If the tooth gets ankylosed in future, then if the examiner mentions a high-pitched metallic sound or simply a high-pitched tone on percussion, then the answer becomes replacement resorption, right? The second best answer, of course, is external resorption. Image-based question for electric pulp tester. This question actually came in your May INI also. So we did that during that time also. So you know, pink colored, pinkish reddish colored electrolyte was shown in the image. This is the, you know, electrode of your electric pulp tester, and no doubt electric pulp tester is the plain and simple answer, friends, right? So electric electric pulp tester is your answer. Which type of isolation is best for vital pulp therapy? Forget about anything else. Vital pulp therapy, whether endo, whether class 1 restoration, whether amalgam, whether composite, whether direct filling gold, the best type of isolation, no doubt, is your rubber dam. 9-year-old girl, age was given, reported with Ellie's class 3 fracture, great. In an upper anterior tooth, fine. 24 hours after with swelling and pain. Right? Now swelling, don't confuse this swelling with like a periapical infection or something. It's like post-traumatic swelling. After 24 hours, I mean, the tooth doesn't undergo, immediate necrosis or, infection with bacteria, right? The catch here is 24 hours. Within the first 24 to 48 hours, the irreversible inflammation in the pulp is restricted to the coronal pulp in the coronal 2 to 3 mm. So what do you do? When you have a 9-year-old child who has an open apex case, you know that you want apexogenesis to take place, and on top of that, the child's parents are so, well aware of the fact that there is no point in procrastinating, there is no point in delaying treatment. They're reporting to you within the first 24 hours. What better can you ask for? You have to just remove the coronal pulp, that too only a portion, coronal most portion, 2 to 3 mm. 2 to 3 mm of the coronal most portion of the irreversibly inflamed pulp. Give a direct pulp dressing, right? After doing your access prep, after removing the irreversibly inflamed pulp, put your MTA or biodentine as your, pulpal medicament and try to preserve the rest of the pulp and let apexogenesis take place. Right, guys? So the answer is partial pulpotomy, which is also known as Schweck pulpotomy, which is also known as shallow pulpotomy. So that's the answer. Schweck pulpotomy was given as one of the options. So no doubt, undoubtedly, this becomes your answer, guys. Right? Ellie's class 3 fracture, everything is pointing towards Schweck pulpotomy. Plasticizer is added to resin polymer. Plasticizer is added to resin polymer. It basically decreases the glass transition temperature or the fusion temperature or the softening temperature. That's a often repeated MCQ present in all your question banks, no doubt about this. All ceramic laminates are luted with. All ceramic laminates is basically what? PLV, porcelain laminate veneer, right? So how do you lute it? You basically have the laminate surface which is etched with hydrofluoric acid, 9 to 10% hydrofluoric acid for 60 seconds. That is 1 minute to 100 seconds. Then you apply so first you etch the surface of the porcelain laminate veneer, dry it, then apply your silane coupling agent, right? That is the preparation of your laminate. What do you do on your tooth surface? You do your etching, then apply your adhesive, right? And that to a dual cure adhesive, dual cure bonding agent or adhesive. Then you apply what? Then you apply your resin cement, dual cure resin cement onto your inside of your porcelain laminate surface. Put it on the tooth structure, cure it, do light curing. So the answer actually is, this question is actually very simple. It's simply asking you what is the cement that is used for porcelain laminate veneer. The answer obviously is resin cement. The clinical steps. Previously, about 10 years back, the clinical steps were also asked. So you should remember the clinical steps. You have to prepare your laminate, you have to prepare your tooth surface, and then you have to flow your resin cement onto the inside surface of your laminate and then do light curing. And curing will proceed with both light curing as well as self curing. Therefore, you use dual cure composite, dual cure resin cement. What is the inhibitor added to methyl methacrylate monomer? I mean hydroquinone. That's your often repeated MCQ, right? This chapter of dental polymers has somehow become very favorite of the INI people. In May INI also, they asked you questions pertaining to this, in which they were asking you the Knoop hardness number, the tensile strength of polymethyl methacrylate, and now they're asking you plasticizer, inhibitor in methyl methacrylate, and also ratio of polymer to monomer in acrylics. Often repeated MCQ coming time and again since the past 12 to 15 years. Just memorize this. 3:1 by volume, 2:1 by weight. Simple. No doubt about this. No two ways about this. 3:1, just forget about other options. 3:1 by volume, 2:1 by weight. That's it. Which of the following will undergo maximum number of bends? Now guys, this is a question that is taken directly from your Phillips table from chapter 17 in your Cohen, in your Phillips 12th edition. That is the one which is showing maximum ductility. Cold bend test is also one of the tests of ductility. You have a related question coming in that all of the tests are measures of ductility except. So one is a cold bend test, one is the decrease in cross-sectional area, and the other is percentage elongation, right? So the number of bends a wire can be bent before it undergoes final fracture is a cold bend test, right? So the number of bends out of all these four materials, out of stainless steel, nickel, titanium, cobalt, chromium, nickel, which is alloy, and beta titanium, maximum number of bends are sustained by cobalt, chromium, nickel. The other way in which this question can be asked is, this is also known as alloy. So the other way is that it is the most ductile out of the four. Right? It has the ability to undergo maximum plastic deformation or permanent deformation. Right, friends? What type of deformation is seen when a force is applied perpendicular to the surface? This is interesting. So I have a block of material and I apply a compressive stress on this, right? Then this material is going to elongate along the long axis. So tensile strain is seen. So the answer is tensile strain. Simple enough. Now, this is a tough question here. Not a tough question, simple, commonsensical question. There is carious involvement. No image was shown, simple theory. Carious involvement of mesiobuccal and distobuccal cusp is there in a mandibular molar. What is the ideal restoration? So basically your cusp is involved, but no further data is given. That means buccal and lingual facial and lingual surfaces are intact. That is what we will understand if that is not mentioned. So the ideal restoration will be what? Which will be protecting the cusp. That's one. Which will be protecting the cusp. So you have to do a cuspal coverage restoration. At the same time, it should be conservative. So what is the answer? Only. Now, if the examiner would have further mentioned that there is carious involvement of the cusps and also the patient is very predisposed to caries on the smooth surfaces like facial and lingual surfaces, right? then you better give a full coverage crown instead of an onlay. So here the answer would be onlay, because only this much information was given, that two cusps are also involved in a mandibular molar with caries. Basically, the cusps are undermined with caries. Remove the entire caries. And now when you've realized that you, from the central groove, you've gone beyond 2/3 towards the cuspal tip, which is the inference that we are drawing here, because the examiner is telling us that the cusps are weakened by caries. We are going to cap the cusps, right? So an onlay would be a better answer here. If facial and lingual surfaces are also involved, the patient is too predisposed to caries developing on smooth surfaces also, go for a full coverage crown. Which surface is first involved in caries? That's another, question from cariology and conservative dentistry. It is the interproximal surface, no doubt about this. First involved in caries is interproximal surface. Condensation polymerization is seen in, it is seen in polysulfide, it is seen in condensation silicone. Condensation silicone was not given in the options. Polysulfide is the answer. I'll tell you another very important related question to this. One, what is the byproduct of condensation polymerization in polysulfide? Water. That's one. Second, condensation polymerization is also known as step growth polymerization. Now, another question from impression materials, dental materials. Old patient with reduced mouth opening and friable mucosa. What is the impression material of choice? Now, this is a complete ratification based question. Addition, silicone, heavy body. That's the answer. What happens to a wire if we bend it at room temperature? Basically, we are deforming the wire, right? So we are cold working it. We are strain hardening it. So its hardness increases and its ductility decreases. So anyways, strain hardening is the correct answer. Strain hardening or cold working is the correct answer. It's a question which is taken directly from Rotaloy's chapter. I keep on discussing this in my live classes as well as in the recordings, right? So all in all, a good paper. You had a good combination of new questions, recall questions, conceptual questions, questions from conservative cariology, questions from endodontics. Traumatology is, of course, the favorite of AIMS people. Then you have questions from dental materials. So all in all, as far as my subject is concerned, dental materials, cons and endo, I would rate this as a paper which would be done very well by people who have been studying very hard, because you had good conceptual questions which also had some repeat value also. So people who've been studying hard, who've been revising their concepts repeatedly and doing more and more of MCQs in the previous 5 to 10 years will be rewarded here, right, friends? So this was our nice small session of recall of our INI November examination. I wish you all the very best. Hope all of you do very well, and keep the faith and keep studying hard, guys. Thank you. Okay, apical abscess is also there. Yeah, I mean, why not? See, Shweta, apical abscess is there on the X-ray. It's basically a non-vital tooth, right? So you have to manage before revascularization also, isn't it? You do give a dressing of triple antibiotic paste, or your what do you call, your calcium hydroxide. You completely disinfect the canal, right? And then only do you try for revascularization, isn't it? So why not? Yeah. Right, guys? Thank you and best wishes.